Hello and welcome everyone to the second in the webinar series on diabetes, brought to you by Capital Health Network and the Canberra Health Services. Tonight's webinar focuses on type 2 diabetes, aptly named Beyond Metformin. First, I would like to acknowledge the traditional custodians of the land we are meeting on. I acknowledge and respect their enduring culture and the contribution they make to the life of this city and this region, and I pay my respects to their elders past and present. I also acknowledge and welcome other Aboriginal and Torres Strait Islander people who may be attending tonight's event. I'm Dr. Leonie Harcourt, a GP Education Advisor at Capital Health Network. Also with me tonight is Michaela DeLeva from Capital Health Network and Endocrinologist Dr. Carolyn Petersons from Canberra Health Services. So just a few things before we start. Questions and answers are totally fine throughout the presentation, so please type them into the Q&A section of the Zoom panel, not the chat box, and we will politely interrupt Carolyn throughout the presentation so she can answer any queries. And regarding CPD, please fill in the post-event evaluation survey, and we'll also email you a certificate of attendance, and you're able to report 1.5 hours of educational activities to your CPD home. And also just a reminder for Health Pathways. So the login is together, and the password is for health, although now there is a personalized login that you can create, which will track your time on Health Pathways, and you can use that for CPD as well. So go to the Health Pathways website for that. And there's the, as you may know, there's advice and guidelines on and investigations for many conditions, including a whole gamut of conditions for type 2 diabetes. So we're lucky to have Carolyn again tonight. Kristine wanted to make it, but just was unable to make it tonight. So Kristine is the diabetes educator who spoke in webinar 1. And Carolyn is the Director of Diabetes and Endocrinology at Canberra Hospital. She completed her training in Adelaide before moving to Canberra over 10 years ago. Carolyn has a strong interest in medical education and is currently a national examiner for the College of Physicians and a former director of both pre-vocational training and physician training. As a clinician, she believes in providing high quality, person-centered care and works closely with the multidisciplinary team. So over to you, Carolyn. Thank you very much for tonight.
Thanks very much, Leonie, for that introduction, and apologies that you all now stuck with me for a bit longer because I don't have my educator to break this up a little bit. So I'm going to talk today about the different management options that we have for type 2 diabetes, and acknowledging that compared with when I did my training where we had metformin, sulfonylureas and insulin, we now have a fantastic range of options available to us, but it does just add complexity to the decision-making tree. Leonie has already done an acknowledgement of country, so I will keep moving forward. The outline of my talk got longer when I realised that I could talk for a little bit longer today. So there's a range of things that I'm going to talk through, but essentially a little bit just touching on monitoring and targets, and then a talk through the different agents that we have available for type 2 diabetes at present in the community. I'll look at the recommended national treatment algorithm, and then talk through the effective combinations, and then to really try and put it all together, I've got a number of case examples to talk through where I hope it'll work through some of that decision-making process that we sort of need to do these days to try and decide on which are the best agents for our patients at which particular time point. I'm very happy to take questions at any time as we go, so please feel free to interrupt. So I'm going to start a little bit on monitoring and treatment targets. So in type 2 diabetes, unlike in type 1 diabetes, we really don't recommend regular capillary glucose monitoring for the large majority of patients. So we should all do HbA1cs 3 monthly in an ideal world on our patient population. But as far as capillary glucose goes, we should be monitoring or asking our patients to monitor if they're on insulin, if they're on a sulfonylurea, to look for risk of hypoglycemia, and otherwise, in keeping with choosing wisely, this is not routinely recommended. There are special circumstances, though, where you might ask your patients to be monitoring glucose levels out of the ordinary, including if they're put on glucocorticoids. In particular, high-dose steroids will often cause significant hypoglycemia that you might want to know about before they end up symptomatic. If you're going to have an appointment with them to review medication choices, asking them to monitor a few weeks prior to an appointment can be really quite helpful to make those decisions or guide those decisions. And if you have any concerns at all about hypoglycemia, then even if they're not on insulin or a sulfonylurea, it is worth asking them to do some glucose monitoring. The timing of monitoring is really important. It's so often that people come into clinic and they say, my sugars are great, they sit between 4 and 7. And then you ask if they've checked at any other time of day apart from fasting, and the answer is always no. So not just choosing fasting glucose levels to monitor is really important. If a patient's going to spend the time doing finger pricking and monitoring, then you want to actually really see that diurnal profile, because that will help guide your decision making or your medication dose adjustment. 4 times a day for type 2 diabetes is generally enough. And the easiest time points I find are pre-meals and pre-bed, but otherwise you can do before and 2 hours after a meal. You don't want to be monitoring glucose levels anything less than 2 hours after a meal, because you'll pick up on hypoglycemia that is to be expected and that we wouldn't otherwise actively manage. Just a couple of other comments. One is that there's really a very limited need for continuous or glucose monitoring, so any sensor glucose monitoring. A lot of patients will ask about it because obviously avoiding finger pricking is ideal. The problem is there is no subsidy for this in people with type 2 diabetes, and so it's quite expensive for most people with your flash sensors or your Libre sensors, $95 a fortnight. So unless they're on insulin and they wish to pay that money, there's really no need to encourage them strongly to think about doing that. You can occasionally have diabetes educators who will be able to give them a 1 free trial, and that's helpful again if you're starting or changing certain treatments that you want some more detailed information. But as a rule, I certainly don't advise that people with type 2 use any of the continuous monitoring sensors. The other thing just to remember, though, having said about when to monitor and when not to monitor, is that if people are on insulin, they've got to comply with the drive above 5 rules, which is that they should be checking their glucose levels every ignition turn and every 2 hours on a long car trip. Treatment targets should be individualized. Priority 1 is always safety, in particular really minimizing risk of hypoglycemia. Priority 2 is looking at minimizing the risk of developing long-term complications or any acute symptoms of hypoglycemia. In the younger patients with no significant comorbidities, which would render them more frail, HbA1c targets really should be sitting between 6.5 to 7.2%, give or take, around that 7-ish mark. In the older, more frail patient, an HbA1c sits much higher by preference, so we would much rather target between 7.5 to 9%, which sort of reflects glucose levels sitting between 8 to 14 millimoles per litre. And the reason for that is safety. The first thing you want to avoid in the older, frail person is hypoglycemia, because that is much more likely to cause them significant complications or may in fact also result in death. And you're not going to run into much trouble from acute hypoglycemic symptoms with glucose levels less than 14. So they're not going to end up in hospital dehydrated and with problems if their sugars are sitting at 14 or less. And the risk of developing long-term complications disappears the older that you get, because obviously it takes quite some time to develop those complications. So really aiming for as little hypoglycemia as possible, with otherwise the glucose levels as close to normal as possible, is where our treatment targets sit. A plug for any sort of treatment for type or management of type 2 diabetes cannot ignore lifestyle. Now, I haven't gone into a lot of detail about this, but to be honest, it's probably our most important medication that we have available for type 2 diabetes, and it should be discussed at every appointment if we can. It's really important to make sure that we set achievable goals with our patients. There is no point in telling them that they need to do something that they just won't be able to make happen either at all or in a sustainable way. Improving lifestyle for a couple of weeks isn't particularly useful. We really need this to be a durable and sustainable improvement. It's important, though, that they do have a goal that you can then come back with and reflect with them to see how close they got to that. And the changes that we're trying to target are really trying to address those patient needs. So if we know that they've done some monitoring and glucose levels are high after dinner, then a walk after dinner is the perfect time to try and bring in that exercise, because that will help optimize glycemia at that time point. It's also really helpful to remember that we do have a number of allied health colleagues who we can utilize to assist with these lifestyle modifications, with actually establishing the goals with the patients, and also with monitoring and helping facilitate and to use those care plans for that. Exercise physiologists are a great adjunct to encouraging exercise in our patient population. Dietitians obviously are also very useful at helping provide those sensible ways of people adjusting their diet to make it able to be managed by them, but also optimize glycemic control. I'm going to move on to the oral hypoglycemic agents because I haven't been interrupted yet, but please feel free if there's anything on the other discussion points to bring me back to them if needed. So even though this talk was beyond metformin, you can't talk about type 2 diabetes without touching on metformin. And I've got the French lilac or the Galiga officinalis, which is where metformin is originally derived. I won't spend much time on the boring side of things, but just to remember that metformin increases insulin sensitivity, and it still is the usual first-line agent for type 2 diabetes because it's cheap, but also because it works really very effectively. Ideally, from a tolerability point of view, it's worth starting at a low dose and then up titrating to the maximal tolerated dose. And with metformin, the general rule is still that something is better than nothing. The maximal effective glucose lowering dose is 2 grams a day. There is no real benefit to be derived from going above 2 grams a day from a dosing point of view, but they're much more likely to get side effects. So anything between 250 milligrams to 2,000 milligrams daily is where you want to sit your patients with type 2 diabetes. It's always better tolerated if they take it with food, and the XR formulation is also usually better tolerated. I generally recommend dose increasing by, if they can tolerate it, starting at 500 and going up in 500 milligram increments every 1 to 2 weeks, depending on tolerability. If they get to a point where they get side effects, to bring them back to the previous dose that they tolerated and maintain it there. The adverse effects, I'm sure you all know, are those gastrointestinal adverse effects, bloating, nausea, and diarrhea. We all got taught at med school about lactic acidosis. It doesn't happen unless your dose is more than 4 grams a day, or if there's an acute kidney injury. So in your standard patient, if you treat up to 2 grams a day with metformin, you won't ever see lactic acidosis and really don't need to worry about it. Benefits of metformin is it doesn't have weight gain and it has limited risk of hypoglycemia. It doesn't really give us anything else apart from the insulin sensitization and improving glycemic control. There are no other added bonuses that we'll see with some of the newer agents. It does need to be dose reduced in renal impairment. So if people's kidney function is changing, make sure you think about going back to that metformin dose and reviewing whether it needs to be adjusted. And equally, if that renal function recovers, to bring the dose back up again. And it's contraindicated if creatinine clearance is less than 15 mils per minute. There are no PBS restrictions at all on its prescription. On the flip side, however, there are most PBS restrictions on other drugs being prescribed that necessitate either metformin or sulfonylurea being used. So we do still need to have it in our algorithm at present for PBS prescribing reasons.
Could I ask Carolyn, so with the immediate acting, the dosing says up to 3 grams a day, but the XR is 2 grams a day. Is there any reason for that?
No, I think when the XR formulation came out, everyone just realized that there's no point in going beyond 2 grams a day. Technically, patients could take 3 grams a day of the XR. There's no major difference from that side of things. It's just there's no glycemic control benefit in doing so. So you won't gain anything by having them on the immediate release up to 3,000. It's just 2 grams a day, no matter which type you use, but XR is always better tolerated.
And why does the immediate release still exist?
It's an excellent question. It's a drug that's off patent that people still make is probably my short answer, and it is still cheaper. So, I mean, there will always be a market for it elsewhere around the world, I guess. And there are a number of patients who are on it who tolerate it just fine. But the convenience of being able to take a once a day dose rather than having to split it over multiple time points and having less side effects is a really strong indication. I certainly don't ever start people on the immediate release.
Yeah. And another question, sorry. So is it better to take it at night just because of the cortisol release overnight, or doesn't really matter what time of the day to take it?
Because it's an extended release formulation, it really doesn't matter from a pharmacological point of view. I usually encourage people, if they're going to take it once a day, though, to take it at night, partly as well, you get less side effects. If you're not awake, you won't notice the bloating and a little bit of nausea. So most people, again, will tolerate it a little bit better if it's taken at night. But really, because it's XR, it doesn't matter.
And what do you think about off-label use for people with polycystic ovary and insulin resistance and impaired glucose tolerance?
Yeah, look, I certainly have no issues or concerns with it, and I do use it in those situations as well. I think it's a drug that we know is an insulin sensitizer. So in people who have insulin resistance, it works and it's helpful. Yeah. If they can tolerate it, give them some. It certainly won't cause harm, and it may cause benefit.
And do we need to monitor B12 levels?
I always monitor B12 levels. That's a really good point, and I should have had that on the slide. I always monitor B12 once a year in people on metformin, absolutely.
Yeah. Sorry, one last thing on metformin, because it is a bit of a wonder drug. I know that they're using it orally in gestational diabetes, and it had a category C categorization, but I think people are actually okay with it. Any comment on that?
Yeah, look, so for gestational diabetes, it depends on who you ask and on where they trained or what experience they have as to whether they're comfortable with metformin. So the general Canberra experience is that most clinicians in Canberra don't use it. I did my training in Adelaide, where a lot of the studies were done on metformin in gestational diabetes, and I'm quite happy to use it. There's now some really good, I mean, we've got old historical data from it having been used previously. A lot of the third world countries use metformin regularly for gestational diabetes without any suggestion that there's an increase in adverse events. And we've now got the MIG trials that have got up to 7-year follow-up data, and the next lot's 7 or 10 years, and then the next lot's about to be released soon as well. So there's some really nice longitudinal data following a large cohort of children who were metformin and gestational diabetes babies, and there is no suggestion of any major adverse events at all. There are some slight differences in body composition, but nothing that shows any adverse signals. But there are still some clinicians who just prefer not to use it. In saying that, I think it does have a limited utility. So I think it's probably safe in gestational diabetes, but I think the utility is limited to those where you won't be able to convince them to use insulin. They have an extreme needle phobia, or for whatever reason, insulin isn't going to be safe. And for people with only really mild hypoglycemia in pregnancy, you don't get that quick response. And the problem is, by the time we diagnose gestational diabetes, you really want that glycemic control at target and quickly. And the time for metformin to build up, be tolerated, and be effective, I think you lose a number of weeks of good glycemic control that I don't normally like in pregnancy. So my preference is still to use insulin, but there certainly is a role for it. And in people who were on metformin prior to falling pregnant, I'm certainly comfortable with them continuing it, be that for polycystic ovarian syndrome or be that for type 2 diabetes.
Sorry, you're trying to get beyond metformin.
No, that's all right. I'm very happy to talk about metformin because it's such a commonly prescribed drug. So if there's any questions, happy to take them.
Yeah. So now beyond metformin.
Beyond metformin. So let's go to the sulfonylureas, which are beyond metformin and really now are dropping rapidly down that sort of place in the prescribing algorithm. Whereas, as I said, when I first started, they were our second line agent, or in fact, they were our first line drug for people who were skinnier with type 2 diabetes, is how I was taught back in the day. So sulfonylureas are an insulin secretagogue, but they're fairly indiscriminate. So they just ask the pancreas to push out more insulin all the time. So they are traditionally the second line agent for type 2 diabetes, but that really has now changed with our newer agents that we have that are available. And the side effects of them that have really pushed them down the pathway, apart from that they don't have any other real added benefit, is the risk of hypoglycemia and also of weight gain. And the hypoglycemia is particularly at risk in the elderly and those with renal impairment. And it has a really long duration of action. So you'll see those patients who come in with an acute kidney injury into hospital and they took their glucoside right up to the admission, and then they just don't clear it for a week properly, and they have these really prolonged periods of low glucose levels. So it doesn't clear from the system quickly if you knock off your kidney function. It's contraindicated in severe renal or hepatic impairment. In saying that it has a long duration of action and it doesn't clear, the immediate release formulation gives you much more risk of hypoglycemia. And so certainly my preference is that, and majority of people would recommend that you use a slow release formulation so that you try and minimize that hypoglycemia risk that comes with using sulfonylureas. And you still start low and build up, because even if someone's glycemic control is really terrible, there is still a chance that if you push that insulin out quickly, they will develop hypoglycemia. So starting low and building up. The approximate HbA1c reduction of sulfonylureas is thought to be between 0.5 to 1.3%. I think it's highly variable on the patient as to whether you get that lower or the higher range. Some people will get a really big benefit from it, and others much less so. So it comes with no PBS restrictions. As I said, though, it is paired with metformin, one of the two drugs that the PBS do ask for you to be on before you start one of the newer agents. So it does have a role still in the algorithm for those who can't tolerate metformin in particular. I personally limit its use to those who are on maximal other oral hypoglycemic agents, but just need that little extra improvement in glycemic control and either aren't suitable or don't want to progress on to injection, or if you think you can avoid moving them onto insulin by just topping them up with one extra little agent. I certainly have other colleagues in Canberra who really still put it right up front of the algorithm and think it really does give a lot of benefit. So we all have variable experience, I guess, with its benefit, and some of us think more highly of it than others, but it certainly is still a useful tablet to throw into the mix at times. For me, it just doesn't have any other added benefits, and it does carry hypoglycemia. So for that reason alone, I have it lower down the pathway. Any questions on sulfonylureas?
No questions of sulfonylureas.
So I will sneak on, because most people probably won't be prescribing them these days very much. So I'll move on to the DPP-4 inhibitors, or the gliptins. which are really a very well tolerated oral agent. So they predominantly reduce postprandial glucose is really where you'll see their main benefit. And they do that without the risk of hypoglycemia, which is obviously ideal. They're weight neutral, also a benefit in type 2 diabetes. There is association with pancreatitis, and we've never really seen, clear cause and effect, but essentially for most people, we would just deem them to be contraindicated if there's been a history of pancreatic disease, because you don't want to risk there being a trigger for pancreatitis or other pancreatic issues. Some of the gliptins require a dose reduction for renal function, and others can be used unadjusted at any renal function. So, if you're choosing your preferred drug in a class, I obviously find it much easier to send a patient away and not have to worry about what their renal function does and say, here's your dose, keep taking your dose, doesn't matter how bad it is. And so I find it much easier not to have to worry about adjusting for renal function. But obviously, again, if you do have them on one of the drugs that does need dose adjustment, just to remember that if people's kidney function fluctuates at all. The data suggests that you'll get an approximate A1C reduction of between 0.7 to 1% using it as an adjunct to metformin. I have to admit, I personally find it's probably more on the lower end of that spectrum, and that I can't recall ever seeing a really miraculous drop in HbA1c or a really rapid improvement in glycemic control in these patients on the gliptins in addition to metformin. But it does again play a role in just giving you that extra little bit of improved glucose levels, in particular at those postprandial periods of time. PBS rules for it are that it can be used, and they've just all changed in the recent changes in the last few months. So the current latest listing is that it's to be used in combination with at least one of metformin, sulfonylurea, or insulin, and the glycemic control is not adequately responsive to whichever of those drugs that they're on. So you don't have to have worked your way through them. You just have to have had them on one of those three, and then you can add it into the mix. So it does play a good role in that respect, I guess, in patients with significant renal impairment who you don't want to use metformin or sulfonylurea, and you have them on insulin, but perhaps want to have a little bit of a postprandial benefit or want to reduce the dose of insulin. If you can throw a gliptin into the mix, you will find a little bit of improvement in glycemic control, and it does have a decent role in that patient cohort as well. Important to remember, though, that we don't keep patients on GPP4 inhibitors once we start a GLP-1 agonist, because they work along a similar pathway. So they shouldn't be co-prescribed. So it's a common thing that we often see, is that people have escalated orals and then they've put them onto a GLP-1 injectable, but haven't taken them off the DPP4 inhibitor. So just do remember that when you're adding in a GLP-1, the DPP4 disappears. Otherwise, it's really a tablet that I can't remember a time when someone couldn't tolerate taking it from a side effect profile point of view, which is always helpful. I will move on if there's no questions.
Yep, no questions on gliptins.
Excellent. So SGLT2 inhibitors, or the glyphosins, and they, I guess at the moment with the current PBS prescribing pathways, are probably the drug that we will be starting to use the most, or escalating use of the most. So they block the renal sodium glucose cotransporter, which results in increased urinary glucose excretion. So essentially you're peeing out your excess glucose, which is fantastic, but it does give you a diuretic effect. So patients will report very clearly polyuria. They will potentially get a mild reduction in blood pressure and some mild weight loss. There is a risk, though, of getting dehydrated with it if they don't at all adjust their fluid intake. So it's important to make sure that you remember to tell your patients if they're peeing more that they need to drink more to compensate for that. The beautiful advantage of the SGLT2 inhibitors is the cardioprotective and renoprotective benefits that we found. So there are the independent PBS indications, and I will just put one little disclaimer in there that we ideally don't love using them yet in patients with type 1 diabetes for the cardiac and the renal benefits because of the risk of DKA. So if one of your patients looks like they meet indication for a cardiac or a renal benefit, but they have type 1 diabetes, just defer the use. I'm happy for you to flag it if we haven't thought about discussing it, but please defer the use of that to the endocrinologist. And we often have conversations with the cardiologist and the nephrologist about how we're a little bit concerned about DKA risks in certain patients. Little sidestep. So the adverse effects of the glyphosins predominantly relate to their mechanism of action. So you can get a transient renal impairment, usually transient. Sometimes it lasts a little bit longer and necessitates stopping the medications. But predominantly that transient effect is that they get a little bit dehydrated. But the genitourinary tract infections are really common. So both candidiasis as well as bacterial urinary tract infections. And it's really important to warn your patients early to watch out for them. I always tell my patients that I'm really happy to accept a couple of infections, in particular early in starting it, because if they're really hyperglycemic, they'll get a much higher glycosuria. But once things settle and their glycemic control improves, generally the risk of infection also settles. So I say, look, for the first month or so, if you get a couple of infections, get onto the thrush straight away, see your GP straight away for a urinary tract infection, and see if you can ride it out. But if it's something that keeps coming back and we can't get on top of, then absolutely we should be stopping these medications, because it hasn't settled after a couple of months. It generally won't settle. But really important that they don't just sit on things and get onto it early. Same as for the male patients in particular. I've had a lot of people who, despite knowing that you've had that conversation, they kind of haven't put two and two together and have ended up with significant complications from a genitourinary point of view from these medications, but much higher risk in women than in men. Euglycemic ketoacidosis is that side effect that we all get very concerned about with the SGLT2 inhibitors. And when they first came out in particular, we saw an awful flurry of hospital admissions with euglycemic ketoacidosis. And once we kind of unpacked why people were coming in, there's the two key things that I think really trigger euglycemic ketoacidosis. Sometimes it's just unlucky. Sometimes it's actually just unmasking someone who had underlying autoimmune diabetes. But predominantly it happens if they have a prolonged fast. So in particular in that perioperative state, now the national guidelines for anesthesia say that you hold these medications for 3 days before and after any surgery. And unless it's an emergency procedure, they will not operate unless the medications have been withheld. And so it's really important that the patients remember to flag that if they are having any procedures. And in the setting of an intercurrent illness, so any acute illness, I advise my patients to not take it. If they're sick enough to take a day off work and stay in bed, they should withhold their SGLT2 inhibitor and only restart it when they're well and they're eating and drinking and they're feeling good again. Because otherwise those tend to be the real triggers for euglycemic ketoacidosis. We don't see it with fasting for blood tests. That sort of short fast overnight tends to be fine. Ramadan is a period where I have to admit I get quite concerned about my patients being on SGLT2 inhibitors. The guidelines for the method of managing diabetes in Ramadan say that generally it's okay so long as they keep their fluids up, but if they're not drinking water and your patient is also not eating at all for that really extended period of time, it's probably advisable to get them to hold the SGLT2 inhibitor in that sort of setting as well. So prolonged fast or intercurrent illness. They're good drugs, and it's interesting, the data from all the studies, it gives you an approximate A1C reduction of between 0.5 to 1%. And I have to be honest, I think it's on the high side of that, if not more. You can get a really good response in glycemic control with these drugs. I think they're highly effective. They're certainly the best choice drug for patients with a history of or who are at high risk for heart disease and renal disease because of those other cardioprotective and renoprotective benefits that we've seen come out of all the studies. But important to remember that from a diabetes point of view, you don't get a glucose lowering effect unless the EGFR is greater than 30, because you need that degree of filtration to actually get the glycosuria. So for diabetes, the EGFR cutoff should be greater than 30. The renal guys obviously use it at a lower EGFR from their renoprotective effects from with proteinuria. So the PBS rules for the SGLT2 inhibitors are that they should be used in combination with at least one of metformin, sulfonylurea, or insulin, and not adequately responsive to the above. So again, they now can be very clearly used as a second-line agent once you've started them on something else first. But they cannot be PBS co-prescribed with a GLP-1 agonist, which is a pity because it's a very effective combination, and I'll talk about that a little bit more later. So it can't be used with GLP-1s, but can be used with anything else. And so long as you have a minimum of metformin, sulfonylurea, or insulin, you can use these medications as a second-line agent. They can be co-prescribed with DPP-4 inhibitors, and in fact are often made in combination tablets to minimize pill burden once you get people stabilized on multiple oral agents.
We've got a couple of questions.
Let's go for it.
Yeah. So first one is the SGLT2 inhibitors, so is it only renal protective due to the improvement in HbA1c, or is there something else happening?
No, there's something else happening. So the renal guys, they've actually got their own indication, which is for proteinuria, not in diabetes. So separately, EGFR below a certain point on an ACE. I think they've got to be on an ACE inhibitor and then a degree of proteinuria. So no, there's a completely other mechanism that's helpful. It's not just glycemic control alone, and it's used in patients without diabetes with renal disease now. And
do you know about the use in heart failure? Is it again another pathway?
So it's again, and yeah, it's another mechanism. It's not diabetes related. They're using these drugs now in a lot of people without diabetes who have heart failure. So again, strict requirements about where the ejection fraction needs to sit and other drugs that they're on, but yeah, effective in heart failure management. So I have to admit, I'm not a cardiologist, so I'm not going to talk to their area, but yes, there's definitely added benefits and completely separate from glycemic control.
Yep. Then question, if stopping and starting them, how long does it take to get in and out of the system?
Yeah, look, that's a good question. I guess it does depend on people's renal function, but generally, as I said, 3 days pre-op is enough. So clearly we're happy that 3 days is enough of a clean washout. So a couple of days and there's enough down that they don't get ketoacidotic, and then an extra day to give you a benefit. I guess the other procedure where they really commonly get quite concerned about it is anyone who's having a colonoscopy in particular, or gastroscopy, but the colonoscopy, because all that bowel prep and so on, adds to the risk of dehydration. And so they routinely check ketones in all their patients before they will do, if they're on these drugs, before they do scopes, to make sure that they're not too ketonic before they sedate them. But generally 3 days will be enough time for you to have a washout.
There's a further follow-on question from that one. Yeah. Hot weather and dehydration, any concerns?
Look, just dehydration in general. So, hot weather, increased exercise, other things that go on, bad diarrheal illness, any of those sorts of things, absolutely. So as I said, I generally say to my patients, whatever you're drinking before, if you go to the toilet more often, every time you go, have another glass of water to cover what you're doing. If it's a hot day, drink more than you used to do. Obviously, we don't give that same advice to patients with heart failure, so this is specifically for people with diabetes. But yeah, absolutely, the risk of dehydration, you will see a drop in their EGFR or a rise in creatinine in response to dehydration in patients on SGLT2 inhibitors. And as I said, usually it's transient, but I have had probably a handful of patients that I've had to stop it because, despite weeks, it hasn't turned around, and then we stop it and it takes again several months before you'll see any sort of track back towards where they were at baseline. So interestingly, that DKA risk, and I've had conversations with the cardiac and renal colleagues about this, is that they don't see that DKA risk come out, or sorry, the ketoacidosis risk, I shouldn't say DKA risk, the ketoacidosis risk really come out in their patients who don't have coexisting diabetes as a diagnosis. So theoretically the risk is there, but we are really only seeing that in patients who have diabetes underlying it.
And just to follow on from that again, any risk of hyponatremia if they're drinking a lot?
I haven't seen it, so I'm going to say if it's there, it's a very minor risk. It's not something that we see acutely from people just drinking water to keep their fluids up. And in fact, conversely, so we actually use SGLT2 inhibitors to it can help really with managing SIADH. So we will often give a dose or two in hospital if we get stuck with trying to get people's hyponatremia resolving itself. There is evidence to say that actually it can increase sodium levels, but not out of keeping. So I don't think they can over dilute themselves with water and in the use of an SGLT2 inhibitor. Not worried about the sodiums.
Yeah. Do any of these medications or the other oral agents, apart from metformin, do you have to be cautious with CT scans?
Short answer is no. Long answer is I still encourage these drugs to be stopped if people are sick enough to be in hospital. But if they're well in the community having a CT for other things, no, it's just the metformin. And right. Again, a point that I didn't mention, so thank you for reminding us.
That's right. Yep. Okay. So now beyond
the oral agents. Yep. Now, I have to admit, I am skipping in the oral section. I am completely past the thiazolidine-diones and acarbose because I think they are really drugs that have died a sad death. Acarbose is horribly tolerated, doesn't give you much HbA1c improvement, and that's partly because it's not a great drug for glycemic control, and partly because most people just don't take it the way they should because it gives you bad enough side effects that most people don't tolerate it. So I'm skipping past acarbose completely. The plug for the thiazolidine-diones again is that they were actually a really effective drug at insulin sensitizing patients, but the side effect profile unfortunately way outweighed any benefit they gave from glycemic control. And I can't remember when I last saw a patient on a thiazolidine-dione, and I certainly haven't prescribed one in at least a decade. So I'm going to completely ignore them from the pathway and move on to our non-insulin injectable drugs. Interestingly, it was quite hard to get a picture of Mounjaro that didn't come from a weight loss and slimming website for obvious reasons. But anyway, I found one off the internet from a pharmacy that was slightly more reputable than the others. So again, to go to a little bit of, take a step back to a little bit of the more boring side of things, the incretin drugs stem from the fact that incretins are neuroendocrine hormones produced by the gastrointestinal tract in response to food. And so this is where that postprandial effect comes from. And also the lack of hypoglycemia, because they only work when there's food there to stimulate their production, or their mechanism of action. They are involved in stimulating insulin secretion and in suppressing glucagon secretion. They also suppress appetite and inhibit gastric emptying, and really you describe it as being like a gastroparesis type effect, in that gastric emptying slowing and that satiety then causing a suppression in appetite. So the two major incretin hormones are GLP, or glucagon-like peptide, and a glucose-dependent insulinotropic polypeptide, which I hate saying, but GIP. And these hormones are metabolized by DPP-4. So that's why we don't use DPP-4 agents in combination with the GLP agonist, because it's that same mechanism of action. It's just that the injectables are so much more effective than inhibiting the metabolism. So GLP-1 agonists, the lovely Gila monster's saliva is where they originally were derived from, which is where Xendin came from. In that the Gila monster, when it bites its prey from its saliva, it then drops glucose levels to such a level that the prey becomes comatose and the Gila monster gets a meal. So all the currently available GLP-1 agonists are weekly subcutaneous injections. Everyone knows about the supply issues that we have had over the last couple of years, and they, I think, now are steadily improving. We still get little fluxes here and there where patients for 4 or 6 weeks can't get hold of their medication, or they have to ring around 10 pharmacies. But as a general rule in Canberra at the moment, we seem to be fairly well supplied. Some of the regional towns around us are having not quite so much luck, but we're doing pretty well here on the whole. With that, however, if you've got a patient on one of these drugs, I always say to them, don't wait till you need it. Get your next stock in a week or so in advance so that you don't run out and then have to wait. The adverse effects are, again, gastrointestinal predominantly because of that gastroparesis effect. So nausea and vomiting are the two main things. You can also, again, like with the DPP-4 inhibitors, get a pancreatitis. So again, in patients who have had problems with pancreatitis, generally most of us are reluctant to prescribe them. I have some patients who are prepared to take the risk, and we have that conversation very fully and very frankly. And if they get through life without having any problems, it's fantastic. And if they don't, then we say, well, we're definitely crossing it off the list from next time moving forwards. The beneficial effects also come partly from that gastroparesis, where they get increased satiety, and so they reduce their dietary intake, and it causes weight loss. The way of dealing with those adverse effects, or the beneficial adverse effects of feeling nauseated a lot of the time and really feeling full and not hungry, is to break up the way you eat. So rather than 3 large meals a day, the guidance is that you're much better off with a small grazing diet. So instead of having breakfast, split into 2 or 3 snack portions and eat them as snack portions. So avoiding large meals and avoiding high fat foods are really the 2 key things that patients can do to try and make those side effects much more manageable. So of the current pure GLP-1s that we have available in Australia, we have Trulicity, which is a one-off dose, no dose adjustments. You start it, you take it. It generally has less side effects and is better tolerated, but it also, as a consequence, has less benefit in glycemic control and also in weight loss. Ozempic, which, unless you've been under a rock in recent years, you will hear about very clearly and know about, it does dose increment to make those side effects tolerable. So you start at the quarter dose, you go up to the half dose, and then you get the next pen and go up to the full dose. And that just makes medication tolerability much better, or the side effect tolerability much better. Some people cannot tolerate that full dose or even the half dose, but similar to metformin, my approach is if you want someone to be on it because you need that benefit, that something is better than nothing. And so if they can tolerate the quarter dose but not the half dose, or the half dose but not the full dose, then you can drop them back to that previously tolerated dose. And again, you will still get some benefit from the drug as a general rule. Once you stabilize on whatever that maximum drug is, after 3 months, where your side effects end up is where they will stay for your duration on the drugs. So they don't get better at 6 or 9 months, but they will subside until then. So, you start someone on a dose, you warn them about the side effects, a month later they dose increment, and they need to know that those side effects will get worse again, and then they'll settle, and then they'll increase, and then they'll settle. But wherever they are at that 3-month mark on that final dose is where the side effects hold. Some people find that the side effects are there all the time. Every day of the week, between the injection 1 and injection 2, the side effects don't change. Other people will say that they have a couple of bad days, but the rest of the week is actually pretty tolerable. And strangely, for some people, it happens on days 1 and 2 after the injection. And for some people, it happens on days 3 and 4. And I've never been able to pick which patients it is that attacks which days, but there is definitely an individual variability in when those symptoms are there. So it's really actually quite useful to get your patients to map out when the symptoms are worse, because that can then help them guide what day is the best for them to take the medication. So if you know that you're always going to feel sick on day 3 and 4 and you want to feel good on your weekend, but frankly, Monday and Tuesday are days at work where you can have some grumbling nausea and still survive, then take the drug on a day where you'll get the worst side effects on the days that you can manage them. Similarly, if it's coming up to a wedding or another important do that you want to go to and you don't want the side effects on those days, you can manipulate where you take the drugs so that the side effects are manageable on the day where you don't want them to be really causing you problems. I always use Christmas and Easter as an example as well. You can move the day around a little bit to make life a bit more bearable with it. The other thing is it's meant to be a once a week injection, but the timing of the day doesn't matter. There's no relationship required to any meals. And if you miss the dose on your Monday, which is your normal day, you can take it on Tuesday or Wednesday, and it's still completely fine to go back to Monday the following week. You just need a solid 4 days between injections. So if it's more than that delayed, then you need to reset the day of the week that you have it on, and you can either keep it then on the new day or gently bring it back to your preferred day. Evidence says approximate HbA1c reduction is 0.8 to 0.9%. Now, again, I find that that's lovely that they put that in the studies, but actually it's highly variable, and you get that with most people on it. But some people don't get that benefit. There are some non-responders. They tend to be the people who don't get any side effects at all, whereas those who get the most side effects will actually get a much more dramatic benefit more than that. And people who get significant weight loss, you'll see ongoing improvements in HbA1c reduction for potentially years as the weight continues to come down. So, it's a ballpark parameter, but I'm not convinced anecdotally that really is exactly where people will sit. Again, as I mentioned on the DPP-4 slide, just don't co-prescribe these drugs with a DPP-4 inhibitor. Now, a little side note to retinopathy on this. So there is some evidence that pre-existing retinopathy will worsen with GLP-1 use. And in particular, most of the data for this comes from Ozempic. And we're not sure whether there's something in the drug itself or whether it's just that rapid improvement that you see often in glycemic control is what's worsening the retinopathy. But there certainly is a clear association with these medications and worsening of retinopathy. So it's really important before you start someone on these drugs to make sure that they've had their eyes seen by an optometrist within the last 12 months. If they haven't, make sure they get checked. And if they have pre-existing retinopathy, that they need to be warned that it may get worse. And if it's been 9 months since their last check and they were due one in another couple of months, perhaps get it done a little bit early. And I'm speaking to ophthalmologists about this. They often recommend a 3-month post-initiation optometry checkup, just because if there's been a significant deterioration in their retinopathy, then they may need to be referred on early. But certainly if someone's already on treatment for retinopathy, the ophthalmologist depends on the ophthalmologist. Some ophthalmologists will ask you not to use it. Other ophthalmologists will say, we're already treating the retinopathy. We'll just keep treating, use the drug, because glycemic control ultimately is more important, because that will prevent more further deterioration in retinopathy. But do just use a little bit of caution and make sure that your patients are aware that they need to watch out for any signs of visual deterioration. So the PBS rules for this now have gotten stricter. Everything else got relaxed when they did this revision of the type 2 diabetes medications recently, but I think everything else got relaxed really to enable this to tighten up. And the reason that the PBS rules have tightened up is to try and make sure that we have drug available for people who need it, because of all the difficulties we've had with supply issues over the last few years. So the current rules are that it has to be in combination with at least one of metformin, sulfonylurea or insulin, so same as everything else, and inadequately responsive, same as everything else. But the and here is that they also have to have not achieved a clinically meaningful response to an SGLT2 inhibitor or have a contraindication to an SGLT2 inhibitor. So unless there's a reason why not, or unless they were already on a GLP-1, you've got to step them through an SGLT2 inhibitor before you can now move to a GLP-1. And the but that comes with that, which is the pity about it all, is that they also can't be co-prescribed with an SGLT2 inhibitor. So you try it, you fail it, you take them off it, and then you put them on a GLP-1. And the questions that the PBS ask you when you call up, you're like, well, yes, they were on it, but I'm stopping it, so they won't be on it, but now I have to give it to you. And it's a bit of a clunky conversation that you have. But your first initial prescription now for GLP-1s is no longer a streamlined authority code, but you actually have to call the PBS and answer all the questions in the right order and the right way to be able to get your script for your GLP-1s now. But it is helping supply issues, so a useful process.
So if people started semaglutide before that change, they can still stay on it. You don't have to.
They can stay on it, absolutely. So if they've not tried one, but they're already on it, they can stay on it. So the initial script is no longer streamlined and you have to go through this process. But the ongoing, it's just an ongoing and it's a streamlined code. So if someone was already on it with or without an SGLT2 inhibitor previously, it's fine to continue.
Yeah. And is a contraindication to the SGL2, would that be like intractable thrush or?
Yeah, so absolutely. So if they have either renal impairment that deteriorated with it that didn't resolve, or intractable urinary tract infections of any sort, absolutely. They're really the two main ones that you'll come up against. And I guess a previous episode of DKA or ketoacidosis with an SGLT2 inhibitor is another contraindication.
We have a question from the audience. So is there anything to help determine who will be responders and who will have side effects? Is it genetic or epigenetic variation?
Excellent question. Short answer is don't know. It's a try and fail thing for all of us. We have nothing that we can use to test. There is nothing phenotypically that you see in your patients that tell you if they will or they won't. You can get incredible responses in glycemic control in people who are not overweight or obese with these drugs. So it's more than just the weight loss mechanism. So I don't think, I'm sure someone is looking into it, but I haven't seen anything that tells you how you figure out who will or won't respond. Apart from there are some people who just don't, and we don't know why. Or maybe someone knows why who's cleverer than me, but I don't know why.
Right. Yeah. With the eye question, if you're using it for weight loss rather than diabetes, should you recommend they get an eye check as well? Or
if they've got no risk for any underlying retinopathy concerns, no, that's fine. If you're using it for a weight loss mechanism, there's no flag on it. It's really that diabetic retinopathy for some reason deteriorates. And as I said, it's postulated there may just be that drop in glycemic control, also the drop in glucose levels with that sudden improvement that you see is enough to trigger it. We do see significant deteriorations in patients with type 1 who have pre-existing retinopathy when they go from very high A1Cs to very rapidly normal glucose levels. Deteriorate, like significant deteriorations in retinopathy are seen. So I suspect it's probably a glucose lowering effect more than the drug itself.
And would it be possible to give patients, if they get nausea on day 1 and 2, to give them some Maxolon for the day 1 and 2? Or
yeah, some people use it. There's no reason why you can't. And some people do find that they really do need it. But to be honest, most patients, if you can change that diet, they will be able to tolerate it more often than not. But you really have to push them hard to ditch anything that's fatty, come down to those really small little grazing things. And if they're not hungry, just not to eat. So that real ability to be in tune with what their body is telling them that they need to do. And most of the time they manage. But yeah, absolutely. There are some people who do need antiemetics, and there's no problem at all with having that.
Yeah. And there's also, it always talks about thyroid issues as one of the contraindications. So are we asking them, it's usually thyroid cancer.
Yeah.
But
So
are we asking them about thyroid?
So I didn't put it up there because it's something that we've really not seen translate across to humans. So when they first started studying these drugs, they saw a signal for medullary thyroid cancer in rats. There's been no signal that we've seen of increased rates of medullary thyroid cancer in humans in using this. And the amount that now it's been broadly used in the community, we really haven't seen an uptick in thyroid cancer rates, full stop. So associated with this drug. So I don't think anyone really thinks it's something that has translated across to humans, but technically it is still in the warning. So if someone's had a history of thyroid cancer, I won't prescribe it unless they say to me that they definitely want it and they're happy to take that risk. And again, if you have a full and frank discussion and they've already had a thyroidectomy, to be honest, it's probably fine. If they have a family history of thyroid cancer, then again, it's a discussion point, which is it's a risk factor. You already carry a risk factor. We can't tell you whether or not it really does translate to humans, but we haven't seen a signal. What do you want to do? And again, you'll probably get a 50-50 response. So yes, it's there. It's fine print, but I have to admit, I can't tell you how many times I prescribed this drug, and I have never once seen someone come back with thyroid cancer. And we've really been going back to Byetta, before Bydureon, before Trulicity and Ozempic, and we've been using these drugs now nearly for a decade in really common usage, and we haven't seen that rate of thyroid cancer that we would expect if it was a real problem.
I've had a couple of patients who've had a downtick in their mood and is that a like it's been a bit more than I would have expected just to be random.
Yeah, look, you do hear some people talk about that. I've probably, again, only had a couple of patients who have really come back and said that they noticed that and they didn't love it, and one who stopped the drug because of it. But it's a very small handful, and they don't have to have a pre-existing, underlying mood disorder for it to be a problem. So, yes, there is something there. It's not something that we would, that would stop us from using it in people with underlying mood disorders, because we're not seeing it, really convincingly in a certain patient cohort or population.
Yeah. Okay. I think that's exhausted
The
GLP-1.
GLP-1s,
Yep.
excellent. Yep. So I am going to just very briefly touch on the dual GLP-1 GIP agonist that we have available, which is Mounjaro or tirzepatide, because it's a pity it's not PBS listed. And I think at some stage I'm hopeful that it will be, if they ever decide that they're not making enough money and want to drop their price point to be a PBS listed drug. It's an incredibly effective medication for diabetes, also for weight loss, but that's a separate webinar. So again, it's a weekly subcutaneous injection. The side effect profile is just really very similar to the GLP-1 agonist, and the benefits are really similar to the GLP-1 agonist, but they're amplified. So just to give an idea, the approximate HbA1c reduction of tirzepatide in combination with metformin is an additional 0.2 to 0.6% when compared with semaglutide. So you're adding another 0.5% A1C reduction by adding the GIP into that drug combination. So you get a between 1 to 1.5% HbA1c reduction estimated. The weight loss again is amplified. And strangely, while the side effect profile is similar and the benefits are greater, I have to be honest, I find most patients tolerate the side effects better than they do Ozempic. And I can't quite figure out why that is, but for some reason they'll come in and say, yeah, I've got a bit of nausea and I've lost a lot of weight, but it's nowhere near that same degree of, oh, I just feel horrible for X days of the week with this drug. So somehow it's better tolerated. I don't know, maybe if you're spending that amount of money on medication, you don't want to feel sick from it, but clearly there's something in there that makes it not quite so intolerable. It's a dose escalation. You start at 2.5 milligrams weekly and you go up in 2.5 milligram increments every month, as tolerated and as per your desired benefit. So the maximum dose is 15 milligrams weekly, and I've never needed anyone on 15 milligrams weekly. I find most people get a really good response between 7.5 to 10 milligrams as a dose. The cost is horrible, and that's why I also stop at the 10 milligram dose, because once you get above that, it goes up to $700 a month. But the 2.5 milligram dose is much more palatable, and it's just been price dropped recently. But usually, because it's not PBS listed at all, you're spending about $545 on the 7.5 or 10 milligram dose, which is certainly not cheap. It's not on PBS. There's not any mutterings that we're going to anticipate it coming onto PBS anytime soon, but it is now TGA listed in Australia, both for diabetes and for weight loss. And if people can afford it, it is highly effective. Really a very good medication from a benefit point of view. So I'm going to briefly touch on insulin, and I apologize for those who are in the last webinar, because you will see some of the same slides, but I'm not going to labor the points too heavily. Just a reminder that we have a massive range of insulins out there. For type 2 diabetes, we kind of pull back a little bit on what we will utilize. And so predominantly you'll find that we'll use either Optishilin or Toujeo if it's large doses of insulin glargine as our basal insulin. We may potentially use a little bit of a rapid-acting insulin analog, so a Pitranova Rapid or Humalog or Fiasp. For a mixed insulin, you'll find most endocrinologists these days are leaning more towards Ryzodeg because it's got a really nice profile and we like it much more as a mixed insulin. But otherwise, Novamix or Humalog mix is also used. So the insulin regimens in type 2 diabetes are a little bit more broad, I guess, than we use in type 1, because really in type 1 we're doing basal bolus unless there's a good reason not to. So for a large proportion of patients who do need insulin in type 2 diabetes, you'll get away with a once a day dose of a basal insulin, maybe a twice a day dose if you find you get wear off, or they're on a really big dose and they need to double inject anyway, you might split it to twice a day. But most people will use insulin glargine, be that Optishilin or Toujeo, which is just the U300 insulin. The benefits of Toujeo are if you're giving a really large dose, 80 units of insulin, you'll much better absorb it if you're using the U300 because the volume that you're injecting subcutaneously is smaller. Otherwise, there's no great benefit of Toujeo over Opticillin. Mixed insulins are commonly used in type 2 diabetes. If you're using Ryzodeg, you can get away with it being daily. If you're using Novamix or Humalog Mix, generally it'll be twice daily or rarely 3 times a day. And I say rarely just because, usually you'll let people get away with one meal without, worrying too much about their glycemic control, and you'll catch it up at dinner time. But using a once a day dose of Ryzodeg with the highest carb meal of the day, be that breakfast, lunch or dinner, can be really effective at stopping that postprandial hyperglycemia from the one high carb meal or the biggest carb meal, and then giving them a really nice steady basal for the rest of the time. And so if I'm using a mixed insulin, that's certainly where you'll find most of us going at the moment in type 2 diabetes. And you can use it once a day or twice a day, but you can't use Ryzodeg 3 times a day just because of the degludec action profile. Some people use Basal Plus, and before Ryzodeg came in, I didn't uncommonly use a Basal Plus regimen where you have them on a once a day basal, so insulin glargine predominantly, and then again for the highest carb meal of the day, you'll throw in your rapid insulin just to stop that postprandial hyperglycemia. Some people will eventually progress to basal bolus, but that is much less common in type 2 diabetes. We tend to use that more, I guess, in people who have end-stage renal failure and can't tolerate any of the other medications. But even in them, often we can get away with a BD Ryzodeg or BD mixed formulation. The aim of insulin in type 2 diabetes is to use the lowest dose of insulin that you can with the fewest injections that you need to gain your target glycemic control. We do sometimes use it fairly early in the piece as a bridge if someone's got really marked hyperglycemia, just until those orals kick in and become effective. And especially if someone presents either very acutely with high levels or has just progressed to such a point that they have glucose levels that sit in the 20s most of the time. They're often quite glucotoxic, and the tablets just won't cut the mustard. But once you get them out of that glucotoxic state with a few months of insulin, you can often really effectively start orals and quite quickly withdraw the insulin away and get good glycemic control. But it's often a really good bridge as a starting point. And ultimately now, if possible, if you can wean off the insulin and bring in other medications and optimizing the lifestyle, then that's the ideal. So it's a slightly badly worded sentence at the bottom, but basically lowest amount that you can, for the least amount of time possible. Your side effects of insulin are obviously hypoglycemia, and the other main one is weight gain. And I generally will tell my patients that I'll accept responsibility for about 4 kilograms of weight gain once they start insulin. Anything beyond 4, I get them to take some responsibility for, but I'll own 4 kilos. But for a lot of people, 4 kilos is quite significant. When you're trying to also at the same time get them to lose weight, because that that's going to optimize their glycemic control and reduce their insulin resistance. And so, insulin really is, I guess, the last choice drug for that perspective as well. And it has no other added benefits apart from glycemic control. Any questions about insulin? Otherwise, I'm going to try and put it all together.
Just how often should they be monitoring their insulin or their sugars in the day if they're on insulin?
Yeah, so look, the drive above 5 rules are certainly one thing that you have to factor into it. So every ignition turn and every 2 hours on a long car trip. Otherwise, it depends on what insulin they're on. So I like, if they're on a mixed insulin, to see what both components of that insulin have done. So if I give someone Ryzodeg once a day, I would like to see what their glucose levels are fasting, to see what that basal part of insulin Ryzodeg is doing. And I'd also like to see before dinner and before bed if possible, so I know that rapid dose is the right rapid dose, because they're the 2 rate limiting factors for you increasing or decreasing the doses, how much the background insulin's working and how much the rapid component's working. But really, as a general rule, if someone's on a basal insulin, I'll ask them to check their fasting every morning in an ideal world. And obviously I'm talking about an ideal world because I know that a lot of patients out there don't want to check their glucose levels every day. But if you can get things the way you want, it should be fasting to see what the basal's doing. And then I ask them to a couple of times a week to look at other different time points so you can get that diurnal profile. So, maybe on a Monday they'll check before breakfast and before lunch, and on a Tuesday they'll do before breakfast and before dinner, and on a Wednesday they'll do before breakfast and before bed, and then they might have a day of just doing fasting, and then the next day they can go back and do before breakfast and before lunch and mix it up a little bit so that you can see across the time points what's happening. Partly because that'll tell me if I've got them on the right insulin combination for them and the right dose of insulin for them, but also because it helps them know what impact everything else is having on glycemic control. So if you wake up in the morning and you know your fasting levels are 5, you think, great, my insulins are doing a really good job, but then they come and see you and their A1C is 9.5%. It's hard to put that together unless you can say yes, but you can see that every day after lunch, your glucose levels go high. And then every afternoon after you go for your walk, your glucose levels drop significantly. So look what your exercise is doing. That's great. We want you to do more or to do it at this time point. And actually, you either need to change what you eat for lunch, or we need to try and give you something to cover that meal, because clearly what we're doing here is not working from a glycemic control point of view. And that's what you want to target, is those big curves and changes in glucose levels. Does that make sense?
Yep, that makes sense. And here's a very interesting question. What's the best choice of medications for diabetes secondary to hemochromatosis?
So in hemochromatosis, your pancreas essentially is not doing what it should be doing because of that iron overload. So, or deposition, I guess. So insulin is predominantly going to be probably where you end up. But you can try and build up to that point if you can get away without it and they don't have a low C-peptide and they're not ketotic and they're not very hyperglycemic. You can try other medications first. So for that, though, you don't want, you're going to find that an insulin secretagogue, so your sulfonylureas, aren't particularly helpful, because all they're doing is getting that pancreas to push out more insulin where already it's struggling to make it. So I would normally put them on metformin. You can try an SGLT2 inhibitor so long as their C-peptide is not low. If their C-peptide is low, and that's definitely a clear indication to check your C-peptide first and make sure they're making enough insulin. Otherwise, you'll end up putting them into ketoacidosis. But if their C-peptide isn't low, then an SGLT2 inhibitor would be a reasonable choice. Equally, potentially, if they would gain some benefit from weight loss and lifestyle optimization, a GLP-1 wouldn't be an unreasonable option as a stepping stone. But in all honesty, most people, you'll find that you'll end up on insulin. So sometimes it's easier just to have that conversation and bite the bullet and say, let's use metformin to reduce how much you need, and we'll whack some insulin on fairly early.
Do people on insulin on type 2s, when they don't have the same sick day issues that type 1s have?
They still can. So I mean, any of us when we're sick will get a stress hyperglycemia response. So you will still see that if you've got a gastrointestinal illness, again, if you're not getting your food in, or you're not you're losing from vomiting and diarrhea, then again you still do need those same sort of sick day plans. So we'll normally give them a similar management plan, but it's less extreme, and obviously the risk of ketoacidosis doesn't tend to be there. You can still get people who are ketosis prone type 2 though. So usually you'll find those are the people who are acutely hyperglycemic and diagnosed in a DKA setting, and then actually when you have time to unravel it all and get rid of the glucose toxicity, you'll realize they have type 2 and not type 1. But you can still have people end up with DKA. So we still generally encourage them to make sure that they keep their fluids up, they monitor their glucose more, and they adjust their insulin if they need to with type 2 diabetes as well.
Okay.
COVID is one of those things that pushes glucose levels up horribly. It has a really nasty stress hyperglycemia and insulin resistant sort of response. So anyone with diabetes who's had COVID will tell you that their glucose levels hit really high and they just didn't respond to anything and took ages to come back down again.
Right.
I will try and put it all together at this point.
Fabulous.
Excellent. So look, this is the Australian Diabetes Society and I think Diabetes Australia T2D algorithm, which really, if you sort of look at it in a way with a slightly cynical eye, it just lists all the options and says, go forth. But working from the left of the screen to the right of the screen is what they recommend. So metformin is your first line monotherapy unless it's otherwise contraindicated or not tolerated. Second line therapy, as I said, now really we're looking at an SGLT2 inhibitor for most. Interestingly, they put DPP4 inhibitors a little bit further along the chain, and I think that's for two reasons. One is that you get slightly less glycemic control benefit, and you also don't get the other added benefits that you'll see with the SGLT2 inhibitors and the GLP-1 agents. And then there's the multiple options, which is the choose your own adventure. So I cut the bit off the top here, and I should acknowledge that it did say lifestyle first and foremost, because obviously that's really important. But the recommendation is every 3 months you review. If we're not meeting, then we escalate up another step. I guess with that though, two things to say. One is that lifestyle often drops off, so that may be something that they just need a bit of a reminder and encouragement to pick up again. And then compliance is the other thing too. So just because the drug isn't working doesn't mean that they're taking it, and it's not working. It might mean that they're not taking it and it's not working. But essentially, I guess it sort of moves along the way that I have suggested in what I was saying, which is metformin, SGLT2 inhibitor, or if you need a little bit extra, only a DPP4 inhibitor, or if they're contraindications, and then a GLP-1 would be your preferable. Your sulfonylureas, maybe third line, but certainly not second line these days. And again, insulin down the track, if we can avoid it, we would prefer to. Now, I'm going to talk about this a bit more on the next slide, but equally they have also acknowledged it here, which is the combination of GLP-1s and SGLT2s. And I'm going to come back to that because I think it's a really helpful combination for a lot of patients. It's just not on PBS. So I guess when you're choosing your second and third line medications, the factors to consider are what degree of additional improvement in glycemic control do you need? Are you pretty close, but you just want a little bit more? You don't want a drug that's going to give someone side effects, but you want a bit better. Give them a DPP4 inhibitor. It's easy, it's painless, and it will work for a little bit. What are their comorbidities? So what are their comorbidities that will stop you giving them a drug? Or what are their comorbidities that will guide you towards giving them a certain drug? So those additional benefits that will be derived from your medications. Do they have any glucose monitoring that they've been doing, which will show you where you want to target the high glucose levels? Is it postprandial? Is it fasting? Is that going to drive you to one medication or another? What's their renal function? Because that will potentially knock out a few different medication options for you. And do they have any contraindications, be they relative or absolute, to some of these medications? Any other safety factors for the patient? Are they someone who you don't want to have any risk of hypoglycemia because they spend their day climbing a ladder, or truck drivers or any commercial license holder is another one where it may change your choice of medication purely because of their occupational risk. And then needle phobia obviously is a big one for a lot of people. The PBS combinations I've gone through already, but the non-PBS combination that I haven't really talked about, but which is a really good therapeutic option, and it's a pity it's not a PBS combination, is the GLP-1 agonist and the SGLT2 inhibitor. They work really well together. So if you get to a point in your prescribing where you've got them on metformin and an SGLT2 inhibitor, and you want them to be on a GLP-1 in combination, and you don't really want to stop a drug that's worked pretty well but hasn't quite got to your target, to give them another medication that will work but also might not quite get them to target. Your option, or the best option for the patient, is to have the GLP-1 prescribed on PBS. If there are any alternate indications for an SGLT2 inhibitor that they meet, like heart failure or renal impairment, then you can co-prescribe that on PBS quite happily, because you've just got to use your PBS code for your renal or cardiac disease, and then the GLP-1's on for diabetes. But if you can't do that, and you still want to use the combination, then empagliflozin at a dose of 12.5 milligrams daily, so it's normally a 10 milligram a day dose. There is the 25 milligram formulation, but you get very little benefit in glycemic control going from 10 to 25 milligrams. But if you buy a box of 25 milligram tablets, which cost you non-PBS $61.50, and you take half a tablet a day, then you get 60 days worth of medications for your $61.50, which for most people, and I'm talking about even people that I see in a public clinic who have very little means available, most of them can say, you know what, I can get $60 every 2 months to get a tablet that's going to make my diabetes really good. So it is a nice way around that PBS difficulty that we have to get a good drug combination, which is very effective in a lot and will ward off insulin, which is obviously what we're trying to avoid. So I thought I'd go through some case examples to try and, I guess, make more sense of it than saying, here's an algorithm, go and figure it out, which hopefully will work in this forum. I always normally like making it much more interactive, but anyway, you're stuck listening to me, so I'm very happy for any questions and feedback along the way on these cases, or things that they trigger to talk about. So the first example that I was going to work through is a 48-year-old woman who is overweight, and she has a 2-year history of type 2 diabetes. She's prescribed metformin XR 2,000 milligrams daily, and her HbA1c had been reasonably well controlled, but recently has increased from 7.3% to 7.9% on her routine 3-monthly monitoring. Her only relevant past medical history is gestational diabetes. She also has a family history of type 2 diabetes, so this was always going to happen. And she's a retail store manager, so on her feet during the day, in a client-facing role. So recommendations, obviously, first and foremost for this woman will be diet and exercise optimization. So yes, she's on her feet all day, but is there anything else that she can do to try and bring that HbA1c down? And you may find that, in fact, that's what you do and that's all you need to do for this woman. And if she thinks about it, she can probably find a couple of low-hanging fruit with her diet that will definitely improve glycemic control. And yes, she's on her feet all day, but if she walks to work or parks the car a bit further away, she can probably get a bit of extra exercise in, and that probably will actually be enough to get that A1C back down to where it had been sitting pretty. But if she says, look, I can't do any more than I'm doing, and I really don't think that that's going to make a massive difference, and diet and exercise alone won't be your answer, then you've got two options, and either of them really are quite reasonable in this woman. You can add empagliflozin 10 milligrams daily, or pick an SGLT2 inhibitor, any SGLT2 inhibitor. Sorry, I've started picking random drugs here now rather than classes. Or you can add a DPP4 inhibitor. Either of them will probably get you the glycemic benefit that you want. It's often for patients like this, I find a really important discussion to have, though, around the side effect profile, because while the empagliflozin will be better long-term from the cardioprotective and the renoprotective benefits, for a woman who works as a retail store manager who is somewhere where she needs to be in a space all day and can't duck to the loo every 15 minutes if she needs to, that polyuria that she might get from the SGLT2 inhibitor can actually make it a really difficult medication to tolerate. And so, often you have this conversation with patients. Oh, look, there's two good drugs. They're both fine. They'll both do a good job. One's got some extra added benefits, but it has these side effects. And usually I find that I end up with actually, I'll take the drug without the side effects, but thanks. If it works, fantastic. If it doesn't, then we can go and try the other drug. So just that side effect profile may change what you want to utilize in the patient. But honestly, any of those are good options. In 3 months' time, if there's no further improvement, then you can add on any of the ones that you haven't already used. So if you just use lifestyle modifications, then tuck in your second agent. If you've already tucked in a second agent, throw a third one in. Alternatively, at this point, though, if she was already on an SGLT2 inhibitor for that next 3 months, then you can now swap her to a GLP-1 agonist. So that's the other, I guess, added bonus if you choose the SGLT2 now with the current PBS rules, is that you can say, well, look, you know what, let's give this drug a 3-month trial, but if you really can't tolerate it and it doesn't work for you, then we know what our next step could be, and that could be to go into a GLP-1, and that may be a much better option for her. But equally, if she doesn't want to inject once a week and she's only a bit overweight, there's no harm in staying with the combination of oral medications. Any questions, thoughts, comments, other approaches? Alrighty, case example 2. An 86-year-old man who lives alone and has some assistance with heavy household chores, but otherwise is pretty independent with ADLs and most activities. He has type 2 diabetes and his HbA1c is 8.7%. And he does monitor his glucose levels at home because someone once told him it was a good idea, and they sit between 9 and 14. He's got CKD stage 3 with an eGFR that sits at 58, and he's on sitagliptin metformin as a combined tablet, 50 milligrams twice daily, and that's a good dose for metformin from him. He doesn't get any side effects from that. So recommendations for this man. I am very comfortable that a target A1C for a guy who is 86 years old and lives alone sits between 7.5 to 9%, and those target glucose levels 8 to 14 are really safe and are going to keep him out of trouble. He's not going to develop long-term complications because he's already 86 years old, and what I don't want him to do is to have hypoglycemia. So I would do absolutely nothing with this man's medications. I'd be very comfortable with his A1C of 8.7%. And in fact, I might only check it every 6 months because I'm unlikely to do anything aggressive to change things. Thing to add, though, is that I would also not ask him to do lifestyle modifications for a couple of reasons. One, when you're 86, frankly, if you want cake or chocolate, go forth and eat cake or chocolate. I have no problems with that. But equally, I get very worried with patients at this age who then try and make drastic improvements in their diet, because there's a risk of them then starting to cut out things that they nutritionally also need. So I generally don't encourage dietary changes in patients who are older who come to me with their type 2 diabetes, even if it's poorly controlled. If his mobility is pretty good, I might encourage maybe a walk a day, or get someone to take him out, or an exercise class that's age appropriate, but otherwise I wouldn't really push anything at all. If his eGFR was less than or equal to 45 mils a minute, then it's just important to remember that that sitagliptin dose needs to be reduced, as does the metformin. And if you go, you know what, he's 86 and his renal functions just started declining, actually, I'm just going to change him off the sitagliptin metformin combination and give him linagliptin, so I don't have to worry about that renal function. And the linagliptin, again, it's not necessarily a bad idea, because once you've dose reduced his metformin a little bit, you'll probably find that you'll be able to hold that, and that won't need quite as much adjusting. And if his A1C was 10%, then you've got a slightly harder situation. So I chose the easy bit where I was really comfortable to leave it. But if it was higher, that's where then it's about really discussing options. If it's 10% and he's completely asymptomatic and he feels fine, you can get away with well, look, why don't we try you keeping your fluids up and going for a little bit of an extra walk, and maybe that third extra sneaky chocolate can disappear. But discussing the options, with the patient and family or carers, I think is really helpful. Options that you have are, he's already on a DPP-4 and metformin. You can use an SGLT2 inhibitor, but he will need to be very aware about those genitourinary tract infection risks and the polyuria. And so in particular, I always like patients to take, especially more elderly patients, to take the SGLT2 inhibitor in the morning, because that way they're not likely to get as much nocturia from the SGLT2 inhibitor. I don't like people getting up at night if I can avoid it, to where you're going to fall over and break a hip. So an SGLT2 inhibitor is a reasonable option. As much as I said I avoid sulfonylureas in the elderly, a low-dose sulfonylurea, if he's hypoglycemic and potentially a little bit symptomatic of that, may be suitable, but I wouldn't go above, say, a dose of 60 milligrams a day of glycoside MR. I don't like the risk of going higher, but a tickle of 30 milligrams a day would be fine, and maybe you could push it up to 60 if you needed to. Equally, sometimes a once-a-day low-dose basal insulin alone. I don't like using rapid insulins in older patients if I can avoid it, because the risk of hypoglycemia is there. But if you gave him 8 or 10 units a day of Optisulin, you'd probably find that his glucose levels came down to where you wanted them without a significant risk of hypoglycemia, if he is capable and safe to give his own injections, which it sounds like he probably would be. Alternatively, again, with a once-a-day basal insulin, you can get a family member to come in or pop by, or you can, if they're on any sort of care package, you can get community nurses to come in. And because it doesn't have to relate to food, and really give or take a few hours, you've got a fair range of when you can give a once-a-day dose. It's not an unreasonable option. You'll notice I've left off the GLP-1s, and the reason I've done that is I don't like the rapid weight loss that induces in older people. I think that just risks nutritional state, and I generally will not be prescribing GLP-1s unless they come in absolutely adamant that they want it, and with a very frank conversation about what the risks are. I would generally prefer to avoid, even though the risk of hypoglycemia is less. I think the nutritional risk is not insignificant.
There's a question that I missed before about ending up on insulin. And so with this chap, or with other people who end up on insulin, do you remove some of the orals as well?
Yeah, so it depends is the short answer. I will, if someone's on a sulfonylurea, as soon as I start them on insulin, I'll always stop the sulfonylurea. You don't get any added benefit. If they're needing insulin, clearly their pancreas just can't make enough, so there's no point in pushing it any further with an insulin secretagogue. So I'll get rid of the sulfonylurea. I generally, for the rest of them, unless they're getting side effects that they prefer to avoid, I generally actually keep the other drugs on. And the reason I do that is that it will reduce how much insulin you'll need, which then reduces your risk of hypoglycemia and your risk of weight gain. And again, if you're getting away with just a basal insulin, a lot of these other medications will potentially help with that postprandial hypoglycemia, which then means that you can get away with just a once-a-day dose of insulin glargine, because the other medications are helping with the after meal levels a little bit more. So sulfonylureas I will always stop, but the rest of them generally I'll keep going. Old data sort of says that metformin probably reduces your insulin requirements by about 30%. So it's a not insignificant reduction in how much insulin you're going to need to put someone on, and then the things that come from that you want to try and avoid.
Yeah. Yeah, that's the questions for this one.
Beautiful. All right, case 3. And do let me know, Leanne, if you want me to stop any time for other questions, but I feel like they're kind of rolling in as we go. So case 3 was a 65-year-old woman who's obese with long-standing type 2 diabetes and clearly poor dietary choices. I haven't changed because I can't ever keep up with new terminology. It's not non-alcoholic fatty liver disease anymore. It's MAFLD, I think, now. With the metabolic instead of non-alcoholic. She has some dyslipidemia as well. She's on metformin maximal dose, glycoside MR maximal dose, and linagliptin, the one dose that you can give. HbA1c is 9%. So in addition to diet and exercise, which is a given, in an ideal world, in this woman, we would stop the linagliptin and start her on a GLP-1 agonist. Or in fact, in a really ideal world, where we didn't have to worry about PBS and costs, we'd put her on a GLP-1 GIP dual agonist, but I won't go down that pathway. But PBS requires failure of an SGLT2 inhibitor first. So I would add an SGLT2 inhibitor, and there's no reason why you can't add that on as a fourth drug into the mix. And it's probably, in her case, worth doing that. I'd be very happy to stop the glycoside MR and trade that over as a, from a tablet point, pill burden point of view, to say, look, it's probably not really doing much. Metformin, linagliptin, SGLT2 inhibitor. And then in 3 months, if the HbA1c has not responded, then you stop both the linagliptin and the SGLT2 inhibitor and start her on a GLP-1 agonist, which would be what you'd be hoping to get to. But if she gets really good glycemic control on triple orals, then you're fine to keep going. The reason the GLP-1 would be much more beneficial in her is that if she's got a BMI of 38 and you can get that down with the GLP-1, then in addition to glycemic control, you get the added health benefits of the weight loss as well. But that's your stepwise approach that you now need to go through if you want to use PBS prescribing rules. I'm going to guess that one's fairly straightforward and simple, and I'll work onto a 65-year-old truck driver.
Can I just ask a question? So there was some talk about pioglitazone being used for fatty liver. Is that something, or no comment?
So I haven't seen the gastroenterologists use it yet. I don't know if they are. We stopped using it in diabetes because of the bladder cancer risk, as well as, even though the rosiglitazone cardiac risk didn't seem to translate across to pioglitazone, there was still enough of a risk of cardiac disease from what we thought was potentially a class effect that we really stopped using it. So, look, no reason why it wouldn't be effective. It just depends on the adverse effect profile that you are risking with that, because there was a really clear signal with pio and bladder cancer, which basically it's stopped us using it, and the rosiglitazone went off the market well before that because it had an even clearer signal with cardiac disease. The gastroenterologists really like GLP-1 agonists. They're very comfortable with us using metformin and GLP-1s in any of our patients with fatty liver disease, because it's really effective both from a weight loss point of view and also from a general fat reduction point of view. So they're always happy if we use those drugs as a rule.
Right. Yep. Thanks.
Beautiful. 65-year-old truck driver, and I put that in so that we can have the conversation about commercial licensing. Type 2 diabetes, ischemic heart disease, hypertension, dyslipidemia, and sleep apnea. I'm painting a very clear picture of a certain person whose BMI is 32, their A1C is 8.8%, and they don't monitor glucose levels, which is reasonably appropriate because there are metformin maximum dose, glycoside maximum dose, and linagliptin maximum dose. So again, lifestyle modifications, if you can, are going to be of significant benefit here for a few reasons. One is it's going to make his life much easier as a truck driver if we don't have to start him on insulin. And because generally as a truck driver, it's really hard to eat well and really hard to exercise. And so there are conversations to have about how we can try and improve lifestyle while living a really difficult lifestyle for that. And I acknowledge it's incredibly hard. I've got a lot of truck drivers that spend a lot of time trying to work out what snacks you can put in the truck that will work. Monitoring is important in a patient with a commercial license, in particular while you're modifying medications, but also he's on glycoside, which can cause hypoglycemia. And so really, as someone behind the wheel of a truck, they should be monitoring their glucose levels. So for licensing purposes, as well as for medication modification while behind the wheel of a truck. So what would I do in this man? Look, I would start him on an SGLT2 inhibitor, and I would stop the glycoside. You could argue the toss that, maybe it's doing something, and it might be, but the risk of hypoglycemia is best avoided. So personally, I would want to stop that. Problem with truck drivers and SGLT2 inhibitors, again, is that diuretic effect. So it's a conversation it's important to have beforehand so that he knows that he can expect it, and ideally try and find ways to work around it, because what you're really wanting to avoid, obviously, if possible, is insulin. But a GLP-1 will be highly effective as an alternative. So again, you try it. If it just doesn't work, there's possible for you to consider how much of a contraindication that might be. But your future alternative, and probably what would be best for him and easiest to tolerate, is going to be to stop the linagliptin, and you've already stopped the glycoside, and start a GLP-1. And so that combination of metformin and a GLP-1 would probably actually get you to where you wanted to with him again. I will keep cruising because we're almost at time. Next example was a 53-year-old man who, with a sedentary job, type 2 diabetes with retinopathy, ischemic heart disease, and peripheral neuropathy. So some good microvascular and macrovascular complications from his diabetes. He's overweight and his HbA1c is 13%. And he's currently taking metformin 1 gram BD and dapagliflozin 10 milligrams daily, which is the maximal dose of that SGLT2 inhibitor. This man needs insulin. He might not need insulin for forever, but he definitely needs insulin now with that A1C of 13%. You can add in a DPP-4 inhibitor. You can take him off the dapagliflozin and add in a GLP-1. You can even prescribe him an SGLT2 inhibitor on a private script and give him a GLP-1 on PBS, but that's not going to be enough to get his A1C down from 13%. And in 13%, he will end up in trouble and he's already got complications. So insulin is really the only answer for a patient like this. The choice of insulin and the regimen is obviously, the next decision to make. And that really does depend on his glycemic profile. So if there's any monitoring that's already been done, fantastic. You say, let's have a look at your numbers and we'll see where you're highest and what we can do. If not, then you have two options. One is you can decide that you just put them on a basal insulin and then you get a profile. And once you've got that profile, you can decide if you want to switch that across to a different insulin that will cover a meal. Or if your dietary history is really pretty clear that there's a lot of carbs going in and you're not going to be able to get all of those out, then you could go straight on to a mixed insulin and choosing Ryzodeg at the meal that's the highest carb intake would be a reasonable option. And again, depending on what monitoring you have, sometimes you might choose to do that for more than one meal, but usually you might get away with one meal as a starting point, but potentially increase that mixed insulin out to 2 different meals of the day. It's important, though, to work out if they would cope with multiple types of insulin and if they would cope with or comply with multiple injections a day, because you really want to make sure you get the best bang for your buck with what they're actually going to do. And based on as much information as you have, but equally you don't want to say go away for 2 weeks and then come back and I'll start you on insulin, because they might decide they don't want to come back, or end up with further problems and complications from hyperglycemia in that time point. So a few days of monitoring is fine if you think, look, actually really I'd rather get the right information and start with one once because this is my one chance to get it right. But often it's easier just to start them on something and then review down the track. Because again, even if you just put them on a basal insulin and bring that glucose level down, it's going to be an awful lot better than it is currently, even if you don't get that optimal glycemic control or that profile really where you want it based on the choice that you've made of insulin. Once you've achieved glycemic control with insulin, then you can consider optimizing the non-insulin medications with the aim to either reduce or stop potentially the insulin, depending on what response you get. And so really your options here are, do you think this person would benefit from the addition of a GLP-1, in which case you're taking away your SGLT2 inhibitor? And I have to be honest, potentially not in this case, because you've got ischemic heart disease where you really want the SGLT2 inhibitor on board. They may have another PBS indication for their dapagliflozin, in which case, great, you can add in a GLP-1 as well. But again, they've also got retinopathy, so you want to try and work out how severe that retinopathy is and whether it's stable or not before you then look at sort of putting them on a GLP-1 as well. Any questions about that?
No, we're good.
All right, 2 minutes to go. I've got one more and then I'm done with the case examples, and I just have one little plug for who you should try and refer into us. So
That's great.
the last case example is a 52-year-old man who's obese. Usual lifestyle story that we often see in patients with type 2 diabetes, but he's had type 2 diabetes for actually a really long time and has no complications and has pretty good glycemic control with an A1C of 7.3%. Now he's been on insulin premix for 9 years and metformin, and he comes in to see you for his routine bloods, and you look and go, you know what, your control's great, but you've been on this for a really long time. Could we do something better for you? And the answer is yes. So this is someone where actually we should be aiming to deprescribe insulin and replace it with a different medication, because from 9 years before all these good drugs came out, he was started on insulin because he needed it. But actually we could do better than that for him. So ideally you would deprescribe insulin and replace with a different medication with those additional benefits that will also help with losing weight and reduce his risk of hypoglycemia. The only thing I would say is that he was diagnosed with diabetes at age 40. And so it's just important to make sure you run through that checklist in your mind of, is this a misdiagnosed type 1 or autoimmune diabetes? or is this truly type 2? So what was his weight at diagnosis? Was he heavier than he is now or the same? What's his family history? If you can ask all those questions and convince yourself that you're very comfortable and confident, it's definitely type 2 diabetes, then fantastic, start to deprescribe. But if you're a little uncertain, just check a C-peptide. You don't even have to check the antibodies, but at least check the C-peptide and just make sure that he's got enough insulin production that you're comfortable that you can reduce insulin and replace it with something else. So you're going to continue metformin in this patient, and you're going to start an SGLT2 inhibitor. Or at least I would, I'm not saying you would, I would do this, but they would be my preferences, and look at them trying to reduce that insulin dose. So I would normally advise someone that if I'm starting an SGLT2 inhibitor, I would want to dose reduce the insulin when they start. And you're picking a bit of a random number generation because you don't know how effective it's going to be. But a 25% dose reduction is a reasonable starting point. But then asking them to make sure that they monitor closely and titrate that dose themselves to effect. Once a week, twice a week if they want to, in 10 to 15% dose increments based on their glucose levels. So if their glucose levels go sky high when you suddenly reduce that dose, then you've reduced it too much and you need to build it back up. But if they're actually sitting 4, 5, 6, 7 all the time, then they can keep reducing that insulin as much as they can until they get to the lowest dose of insulin they can be on and still maintain good glycemic control. If you can't stop insulin, then you have two options. You could replace the SGLT2 inhibitor with a GLP-1 and see if that works, because that might be enough to get you off insulin. Or you might need additional orals to completely stop insulin. So you could either then have an SGLT2 inhibitor and a DPP-4, or a GLP-1 and an SGLT2 inhibitor on a private script, or a GLP-1 and a sulfonylurea, again with the metformin. And that might be enough to completely get this man off insulin and improve his weight and reduce his hypoglycemia and reduce his need to monitor glucose levels and actually give him some added cardiac and renal benefits in the process. Final quick thought was just a when to refer. I guess, in the private system, you can refer whoever you want, whenever you want, and most people will see them. In the public system, we really are so strapped for space to see everybody that we need to, that the patients that we want to see are anyone where there's a suspicion of LADA or latent autoimmune diabetes. So that's people with a low C-peptide or positive antibodies, and the antibodies to test are GAD, IA2, and ZNT8. Anyone with acute hypoglycemia, like if they're on a high-dose steroids and you know that for a couple of months they're going to have horrible glucose levels and you want us to help whack them on insulin and monitor and adjust, very happy to see those patients. Anyone who's got a pancreatic cause for their diabetes, and in particular if they're poorly controlled despite metformin and SGLT2 inhibitor, we would be very happy to see them. And otherwise, really, for us, our capacity to see at the moment is an HbA1c of greater than 8.5%, despite compliance with triple orals or dual orals and an injectable, or anyone with significant diabetes-related complications. And the intent is that we help try and adjust medications, get them on the right combination, provide guidance, and then discharge back to primary care, because we just don't have capacity with the volume of referrals we're getting to see people indefinitely anymore with type 2 diabetes. If we can win, fantastic. If we can't, we can only maximize the best drug combination that we can and provide that guidance. And then really there's not a lot else that we can also offer. And on that note, I've used all the time up, Leonie, as promised. And I'm happy to take any more questions if people are still here.
Thank you so much. People are saying it's fabulous and so well thought out. Thanks very much, Carolyn. Could I just ask one more question myself? Sure. So if someone's on a long-term glucocorticoid, say for polymyalgia, how often should you be testing their sugars?
Yeah, look, so if it's long-term and it's low dose, look periodically here and there, but not just fasting. It's that sort of postprandial hypoglycemia that they will often commonly get. So if they're on prednisolone, their morning levels will be great, and then they'll rise during the day. So not just to make sure it's not always a fasting level that you're checking. So if they're low dose long term and they've been fine and you've checked a few times and then you've checked again a couple of months later and they're still fine, they're probably going to be okay, so long as you then keep an eye on their HbA1c. But if you're whacking them up to a really high dose, then it is worth monitoring for at least a few days on that dose. If they've taken 20 milligrams for 3 days and their glucose levels haven't gone up, they're not going to go up on that 20 milligrams. But you want to make sure that in that early period of that really high dose that you do keep an eye on glucose levels. And again, not just fasting. That's going to be the best period of the day on prednisolone. You want to check at other times of day. Right. The dexamethasone fasting is fine because it holds its glycemic profile for a lot longer, but prednisolone peaks up and then wears off by the evening.
Yep. Okay, that was just fantastic. And yeah, there were so many questions, and sorry that we kept on interrupting you, but yeah, just so many questions about managing type 2 diabetes, which is quite complicated when you look at all the different medications. Um, Everyone said it was fabulous. Thank you. The case studies were a great way to draw the information together. So thank you very much. I think people were kind of trying to be modest with their questions at the end to let you finish. But yeah, so thank you so much. So just a message to the audience. If you can fill in the evaluation surveys, we'll send you out a certificate of attendance, 1.5 hours of educational activities. And that's our last webinar for the year, and hope they've been beneficial and enjoyable for you. And we'll put the diabetes webinars up on the Capital Health Network YouTube page. And just season's greetings to everyone, and thanks to our presenters.
Thank you.
Thanks. Good night.